So chapter 5 is on inflammation and healing, and so I'm going to do it in two sections. We're going to first talk about the inflammation response and the body's defenses, and the physiology of inflammation, all of which I hope that you have already heard in anatomy and physiology. And then in the second part, we're going to talk about healing and the types of healing. So again, we will review this information in modalities class next fall, because some of the modalities that we're doing are going to affect this inflammation and affect healing rates. So that's why we want to know about this, because we want to know how the interventions that we apply in a physical therapy setting affect inflammation and healing. So just to review our body defenses, the first line of defense is non-specific. It's defending us against any old thing that comes along. It's a mechanical barrier like unbroken skin and mucous membranes, and secretions such as tears and gastric juices. So anything that comes our way, the first line of defense is going to try to keep it out. So if you have broken skin, if you have a cut or something, your first line of defense is down. And now your second line of defense has to kick in. So the second line of defense is also non-specific. It's phagocytosis, so we have our macrophages, or white blood cells, that are picking up any junk that's in your system. And they're going to take out anything that they recognize as not being as part of your body. And inflammation is our other second line of defense, and we'll talk more specifically about that. So the third line of defense, so if stuff got past the barrier, we have a broken barrier, it got past our phagocytes, and we had an inflammation response, our third line of defense, now we're getting into specific defense. So that's production of specific antibodies or cell-mediated immunity. And in the chapter on the immune system, we will talk about those specifically. So if the first line of defense fails, like we have a cut and something gets past the barrier, the second line of defense, the localized inflammation and phagocytosis, tries to deal with it. If that can't deal with it, our specific defenses have to kick in. And if all the defenses are overcome, that's when we get injury or disease. So our body defenses are important for keeping us healthy. So our normal capillary exchange, usually not all the capillaries in a particular capillary bed are open. Based on the metabolic needs of the cells or the need for removal of waste. So some of them are just kind of resting, maybe getting repaired. They're the standby system, basically. So the movement of fluid and electrolytes and oxygen and nutrients are from the arterial end into the capillary beds. They're based on net hydrostatic pressure. So hydrostatic pressure is a pushing pressure. We talked about this in the fluid chapter. Osmotic pressure is a pulling pressure. So on the arterial end, it's pushing. The venous end, osmotic pressure facilitates movement of fluid, carbon dioxide, and other waste. So that's the pulling pressure. So the arterial end pushes the oxygen and nutrients and fluid and electrolytes into the capillary beds, and the venous end sucks it out by osmotic pressure. Okay, hopefully that's perfectly clear. Inflammation is a protective mechanism, and it's an important basic concept in pathophysiology. Any disorder that has to do with inflammation ends in itis. So arthritis is joint inflammation. Tendinitis is tendon inflammation. Tonsillitis is tonsil inflammation. So any itis is inflammation. And inflammation generally, especially on a local scale, is a normal defense mechanism. That is one of the things that our bodies do. That's our second line of defense, right? Our inflammatory response. The signs and symptoms of inflammation serve as a warning for a problem. So you might have problems hidden within the body, like a bacterium that sneaked in on food. So like, oh my gosh, it got in somehow. It got past our non-specific defenses. It got past our saliva and gastric acid. And now it's lurking there. So that could be like a hidden problem. So inflammation is not the same as infection. However, infection can be one cause of inflammation. There are certainly other causes. But infection has to do with an infectious microorganism, so that lurking bacteria. But inflammation can be caused by other things as well. So here are some causes of inflammation. So direct physical damage, like a cut or a sprain. So I twist my ankle and my ankle swells up. That's inflammation, and it's caused by direct physical damage. Or if I get a paper cut and it swells a little bit. Caustic chemicals like acids or drain cleaners. Drain cleaners usually lye, which is a base. Those can cause inflammation. Ischemia or infarction. So that is where tissues are deprived of oxygenated blood. That can cause inflammation. Allergic reactions can cause inflammation, and in the immune system chapter we will talk about specific types of allergic reactions. In fact, this picture right here is, I believe, an allergic reaction. Extremes of heat or cold can cause inflammation. Foreign bodies like a splinter or glass or anything that is in your body that's not supposed to be there. And infection. And we'll talk about infection in its own separate chapter. So there are some specific steps that happen in the course of inflammation. So whatever is causing it, so all these different causes, whatever's causing it, the steps of inflammation are the same. So the first thing that happens, no matter what causes it, is an injury to capillaries and tissue cells. So any injury to the capillaries and tissue cells will result in the following reactions. So the first thing that happens is bradykinins, which are chemical messengers, are released from injured cells. So the damage to the cells is what releases the chemical messenger. The bradykinins stimulate pain receptors. The pain causes the release of histamine. Histamine is another chemical messenger. So bradykinin and histamine together cause capillary dilation. So if a break in the skin allows bacteria to enter tissue, the neutrophils phagocytize the bacteria, they eat it. And macrophages leave the bloodstream and phagocytize the microbes. So if bacteria is causing it, the chemical messengers are what call the neutrophils and the macrophages, which are white blood cells, to the area to get rid of those microbes. If something else is happening, the neutrophils and the macrophages still show up because they're going to get rid of damaged tissue as well. So, like say that I got my foot crushed in a door. Well, that's my injury to the capillaries and tissue cells. My body the injured cells release bradykinins, which stimulate pain receptors, which stimulate release of histamine. The bradykinin and the histamine cause capillary dilation, so it turns red. I got a break in the skin when my foot got slammed in the door, and unfortunately it allowed bacteria to enter the tissue. But luckily, those histamines sent out the chemical signal to draw the neutrophils to the area to get rid of any bacteria. And then the macrophages show up. They leave the bloodstream from the capillary beds, and they get rid of any junk that's in there. So the process of inflammation is the same regardless of the cause, but the timing varies with the specific cause. So chemical mediators affect blood vessels and nerves in the damaged areas, and that gives you vasodilation, hyperemia, which means more blood in the area, an increase in capillary permeability, so those neutrophils and macrophages can get out into the tissues, and chemotaxis to attract cells of the immune system. So the chemotaxis is the histamines and bradykinins. So some of the treatments that we do in physical therapy cause a localized inflammation response on purpose. So Graston technique is one of the things. We are deliberately trying to cause a localized inflammatory response to call neutrophils and macrophages to the area. So we're trying to stimulate that chemotaxis. But we're doing it on a very localized level, so you might have some redness and a little bit of swelling after doing it, but it doesn't persist. That's the difference between acute and chronic. Acute doesn't persist. So this is a table from the book with chemical mediators in the inflammatory response. So there are a lot of them. We talked about histamines and bradykinins, but there are lots of other ones. So some of them are, and it talks about what their major actions are, which cells create them, and then what their major actions are. So some of them, they work on vasodilation and increased capillary permeability. Totally makes sense because stuff has to get out to the injured cells, macrophages and neutrophils. And some of them have other effects. So, but the vasodilation and increased capillary permeability are major effects of chemical mediators in the inflammatory response. So, local effects of inflammation, redness and warmth, and that's caused by the increased blood flow to the damaged area, that increased capillary permeability. Swelling or localized edema is a shift of protein fluid into the interstitial space. So we increase capillary permeability so we can get the fluids into the interstitial space and get those cells out there doing what they need to do. Pain can be caused by increased fluid pressure on the nerves and release of those chemical mediators. And loss of function can develop if cells lack nutrients, and edema may also interfere with the movement. So I think we've all had some minor injury, like an ankle sprain or something, where it swelled way up and it interfered with our movement. And redness and warmth, swelling, pain, and loss of function, all local effects of inflammation. So erysipelas, which ERY means red, C means patches, and pila is skin. So it's an acute, sometimes recurrent disease caused by bacterial infection. And it's characterized by large raised red patches on the skin, especially on the face and legs, with fever and severe general illness. But it's a bacterial infection that causes an inflammatory response, and it's a localized response. Even though the fever and the general illness, that's the systemic side of it. So, Exudate, there's going to come a time when we have to talk about vomit too, but now we're going to talk about Exudate. So Exudate is the fluid produced by a wound as it heals, and it's part of the normal healing process. So a lot of times, nurses are really big on doing this, but a lot of times if we're working with someone with an active wound, we need to know about what different types of Exudate mean as well. And sometimes it's because we're going to report it to nursing, and then sometimes it's because we're going to do some patient education. So a serous exudate is watery. So serum is the non-cellular part of blood. It's the fluid part of blood. So it's watery, consisting primarily of fluid and a few proteins and some white blood cells. So you can't tell that from looking at it. You can tell that it's watery and doesn't have a particular color. But you can't tell the white blood cells without looking at it under the microscope. Fibrinous exudate is thick, sticky, and has a high cell and fibrin content. So that's when the clotting is starting to happen. We have fibrin as the protein that helps in clotting. And so that sticky exudate, it sounds like healing. We've got clotting. Purulent is thick, yellow-green. It contains more leukocytes, which are white blood cells, more cell debris, and microorganisms, because this is an infected wound. So if we had purulent exudate, that is definitely something that we need to talk to nursing about. If we're in an outpatient setting, we need to send that person right to their doctor's office, and while they're on their way over there, call the doctor's office and talk to them about it. So that happens a lot in outpatient, or not a lot, but many a time I've sent a person over to their doctor's office for unusual exudate. So we talk about the localized effects of inflammation. There can also be some systemic effects. So you get a mild fever, which is called pyrexia. PYR is the prefix meaning fire. Exia is like a condition. So it's common if you have extensive inflammation. We get release of chemical messengers that are called pyrogens that help cause that fever. We get that general malaise, feeling unwell, fatigue, headache, and anorexia, which means loss of appetite. So anorexia nervosa is the psychological effect, but just anorexia by itself means loss of appetite. So this is the table from the book that's on page 71 that talks about why how pyrogens increase body temperature, and basically they reset the temperature control in your hypothalamus to help respond to whatever's going on in your body. So it's just kind of a little step by step and how your body responds to it. Pretty interesting. So we get a lot of changes in the blood with inflammation. We get increased numbers of white blood cells, especially neutrophils, because those guys are going to help with the phagocytosis. We get a different differential count, and differential count is the proportion of each type of white blood cell, and it's depending on the cause of the inflammation, you'll get different proportions of each different type, which is pretty interesting. If you get a chance to look at some lab results, look at them. They're interesting and they tell you a lot. Plasma proteins, we get increased fibrinogen and prothrombin, which are both involved in clotting. And so we get those increased plasma proteins. There is a protein that's called C-reactive protein that's not normally in the blood, but it appears with acute inflammation and tissue necrosis within 24 to 48 hours. So that's something that they can test for and see if you have tissue necrosis. Increased erythrocyte sedimentation rate. So elevated plasma proteins increase the rate at which blood cells settle in a sample. So erythrocyte sedimentation rate is a test that's done that often it's indicating what's going on in the system. So if we have inflammation, we have elevated plasma proteins and increased erythrocyte sedimentation rate. So that's one of the things they can test for right away. If it's not obvious that there's inflammation going on, the elevated ESR, increased ESR, can indicate that, there's an inflammatory process going on in the body. So we get cell enzymes, which are released from the dying cells, and they enter the tissue fluids and blood, and they may indicate the site of inflammation. So if you have a hidden inflammatory process going on in the body, and you've got some systemic symptoms, but they're not sure what are causing it, these tests can help indicate where the problem is. So the course of inflammation and healing, and this is on page 73 in the book. So we get the tissue injury, there's some acute inflammation, you get release of those chemical mediators, which cause vasodilation and increased blood flow, and it results in the symptom of heat and redness. It causes increased capillary permeability, which result in the symptoms of edema and pain. We get increased chemotaxis, which calls the white blood cells to the area. We want that. And we get irritation of nerve endings by those chemical mediators, and that causes pain. So with the increased capillary permeability, we get clotting, which is trying to wall off the area. The phagocytes among the white blood cells remove the cause of cellular debris, and it prepares the body for healing. So if the cause is removed, I take my foot out of the door that it got slammed in, then we're going to progress to healing, where we get scar tissue, regeneration, and resolution. If the cause persists, like maybe I have a tumor that's causing inflammation and it didn't get detected or removed, that can turn into chronic inflammation, causing increased scar tissue and fibrosis. So we want the course of healing to be more to the right side of the chart, where we progress to healing. When we stay more on the left side of the chart, it can progress to chronic inflammation. So the diagnostic test we talked about a little bit when we looked at that one chart, you see increased white blood cells in the blood, so that's leukocytosis. Leuco means white, cyto means cell, and osis means condition. So white blood cell condition, if you want to think of it that way. If the erythrocyte sedimentation rate is elevated, and the picture here is showing the test for erythrocyte sedimentation. So they time it. It's pretty cool. If you've never been to a hospital chemistry lab, it is a fun place if you're into that sort of thing. So elevated ESR can indicate inflammation. The differential count is helpful to distinguish between bacterial and viral infection. And in the microorganism chapter, the infection chapter, we will talk more about that. You can test for circulating plasma proteins. You can test for cell enzymes, which might be elevated. And that is going to indicate if we have tissue necrosis. So potential complications of inflammation. So even though infection can cause inflammation, it can also result from inflammation. So microorganisms can more easily penetrate those edematous or swollen tissues because the capillary beds are open. We have vasodilation. So microorganisms have a little easier time getting in. And some microbes resist phagocytosis. So the macrophages and neutrophils come along and they go, nah, I don't think so, guys. You're not going to eat me. So the inflammatory exudate also provides an excellent medium for microorganisms. So that's why we want to keep an eye on it if there's any exudate. Skeletal muscle spasm may be initiated by inflammation, and it's a protective response to pain. So when our body detects that we have pain in the area, our muscles might contract to protect that area from further damage. Sometimes it kind of shoots us in the foot by making our pain worse, but it's a protective response. Chronic inflammation often follows an acute episode of inflammation. When you get into the chronic phase, there's less swelling and exudate, the presence of more of the cellular component of our defenses, the lymphocytes, the macrophages, and the fibroblasts. The lymphocytes are part of the immune system. The macrophages are still those non-specific white blood cells. And the fibroblasts are the ones that are trying to rebuild the area. You get continued tissue destruction because you still have the setup for that. And you get development of more fibrous scar tissue because the more tissue is destroyed, the more scar tissue is built up. And a granuloma, which is basically a scar tissue capsule almost, might develop around a foreign object. So say that you had a splinter that went deep into your hand and the outer part was removed, but there's still a piece in there. You might also develop that scar tissue, fibrous scar tissue, around that foreign object. So this graphic shows that there are lots of different disease processes that can cause chronic inflammation. So cancer and cardiovascular and diabetes, pancreatitis, inflammatory bowel disease, autoimmune diseases can cause chronic inflammation, arthritis, and renal disease. So a lot of the neurodegenerative diseases also cause chronic inflammation, such as multiple sclerosis. And so chronic inflammation can be a big issue. The potential complications of chronic inflammation, you can get deep ulcers from severe or prolonged inflammation. It's caused by cell necrosis and lack of cell regeneration that cause erosion of the tissue, and it can lead to complications like perforation of the viscera or perforated peritoneum, which then causes peritonitis, which can kill you. And you also can have problems with extensive scar tissue formation, which then can change movement. So inflammation is treated in a lot of ways. So there are drugs that treat inflammation, and not strangely, they're called anti-inflammatories. So aspirin, or acetylsalicylic acid, acetaminophen, Tylenol, both those are used to treat inflammation. The NSAIDs are the non-steroidal anti-inflammatory drugs like ibuprofen, naproxen. There are some prescription NSAIDs. There's one that I hear people talk about. You can get it in Canada, but you can't get it here. It's called Voltaren, but it's still an NSAID, and it still has the potential side effects of an NSAID. glucocorticoids or corticosteroids are more advanced drugs they're not over the counter, that are used to treat inflammation. So if someone gets a cortisone shot for their arthritic joint, that is treatment by corticosteroids. A lot of times when people are having an acute exacerbation of MS, which is an inflammatory response, they will get IV glucocorticoids to deal with the acute inflammation. So this is, of course, from the book, a table talking about all the different types of drugs that are used to treat inflammation and the comparisons of those. And so it says whether it has the actions of the different drugs and the adverse effects. So the things that they're looking for are anti-inflammatory, analgesia, which is pain reduction, and antipyretic, which is fever reduction. So some of them are do one thing or another, and some of them don't. So aspirin does all three. Acetaminophen is not an anti-inflammatory, but it does address analgesia and fever. The NSAIDs do all three. Glucocorticoids, they just address the inflammation. They don't address the other things. And COX-2 inhibitors are another prescription medication that is often used in arthritis. They're anti-inflammatory and analgesic, but they don't address fever. So there are lots of different adverse effects. When you look at that chart, just looking at it and say, which one has the least adverse effects? Tylenol, acetaminophen. It does have some adverse effects, but not on this list. So sometimes it has to be, so the doctor who's recommending these medications, or the nurse practitioner, whoever's the primary care practitioner, will say, is going to take these into account for the individual person. Does it delay blood clotting? That's a big thing. So glucocorticoids do not, Tylenol does not, but NSAIDs and aspirin do. So that might be an issue for someone. So really the practitioner who is prescribing or recommending these medications needs to take into account the effects for the individual person. So glucocorticoids, the way they address inflammation, when you look at that last chart, they don't do anything with analgesia, they don't do anything with fever, but they are anti-inflammatories. That's their reason for being. They do it by decreasing capillary permeability, and it enhances the effectiveness of epinephrine and norepinephrine, which are two hormones in our body that are integral in the sympathetic and parasympathetic nervous system. It also reduces the number of leukocytes and mast cells, and it reduces the immune response. So that can be the cause of some of the side effects, that reduced immune response and reduced leukocytes and mast cells. But it directly affects inflammation. So if you have someone with an acute inflammatory process and you feel that this, the doctor feels that this is the right medication for them, it can be very effective for treating those anti-inflammatory effects. There are the adverse effects. There's a whole cone of them there. So this chart, I like it because it shows that balance between the therapeutic effects and the side effects. And you really have to, that really has to be taken into consideration for the individual person. So atrophy of lymphoid tissue and reduced hemopoiesis, and hemopoiesis is the production of new red blood cells. So you have new blood cells in general. You have an increased risk of infection with glucocorticoids. So is it worth the anti-inflammatory response to get that? It also has catabolic effects, and catabolism is the breakdown part of metabolism. So anabolism is the buildup, catabolism is the breakdown, and those two together is metabolism. So you get decreased protein synthesis and increased tissue breakdown. So that is a problem with glucocorticoids. Delayed healing because of that. Delayed growth in children. So obviously they're going to think long and hard before they give these to children. There has to be a really compelling reason. Retention of sodium and water because of the aldosterone-like effect in the kidneys. And remember when we talked about fluid balance, how the aldosterone has that effect. So glucocorticoids can mimic that in the kidneys, and it can cause you to retain sodium, and water follows sodium, so you can get that retention of water. So you have to take into account the therapeutic effects versus the side effects. Is it the situation where you really need that anti-inflammatory effect versus the potential side effects? So rice therapy for injuries is something we can all do. Rest, ice, compression, and elevation. And that is something that is well within the scope of our practice to recommend to patients. So after surgery, get that foot up above your heart, put ice on it, and do some compression. And rest. Give it some rest. So, this is our ankle sprain. Elevate the ankle above the heart. But rice therapy is appropriate for inflammation, for acute inflammation, and it's very effective as well.